Okay, let's dive right into this explainer on IgG4 related disease. This condition is an absolute master mimic, and honestly, it challenges pretty much everything we thought we knew about certain tumors and inflammatory states. You see, for decades, the medical community looked at conditions like Mucoliche's disease, type 1 autoimmune pancreatitis, and a bunch of other fibrotic syndromes as completely separate organ specific problems. But recent breakthroughs, they've unmasked all of these as just different faces of one single systemic fibroinflammatory condition. Understanding this completely unites those previously siloed diagnoses under one umbrella, and it fundamentally changes how modern clinicians approach mysterious masses.
So, clinically, how does this disease hook us? Well, patients show up with these really frightening, aggressive pseudotumors. Just look at the clinical presentation here. You'll see massive supraorbital swelling involving the lacrimal glands, which is severe dacryoidnitis, along with tremendous enlargement of the submandibular glands, known as sialadenitis. Because these tumefactive lesions are so incredibly destructive and pop up so subacutely, they heavily mimic malignancies. Literally, before the correct diagnosis is made, it is totally common for patients to undergo major life-altering surgeries. We're talking modified Whipple procedures or thyroidectomies, all simply because these pseudotumors look exactly like cancer on a scan. To demystify all this complexity, here's our agenda for today. 1. Clinical presentation. 2. The histopathologic triad. 3. Systemic involvement. 4. The diagnostic workup. And 5. Targeted therapies. Let's get into it. Part 1. Clinical presentation. We call this one the silent pseudotumor. Here's where we hit a massive clinical paradox that really defines this disease. The crucial takeaway is that despite having these huge, tissue-destroying mass lesions, the patient's systemic inflammatory markers tell a completely different story. Patients usually present subacutely, but surprisingly, even with multi-organ disease, they almost never have prominent fevers. And you know those high C-reactive protein or CRP elevations you'd expect to see with such intense inflammation? You generally won't find them here. So you've got this aggressively destructive mass paired with a shockingly quiet serologic profile for acute phase reactants. This silent pseudotumor vibe is exactly why clinicians mistakenly jump straight to a cancer diagnosis instead of thinking about an underlying autoimmune or inflammatory process. Moving to part 2, the hallmark histopathologic triad. Now, we need to zoom deep into the microscopic level. Why? Because even though this disease looks totally different depending on the organ, say the pancreas versus the eyes, the pathology is the great unifier. To nail this diagnosis, you need 3 fundamental pillars. First up, a dense lymphoplasmacytic infiltrate that's just packed with IgG4 positive plasma cells. Second, a very specific type of scarring known as story-form fibrosis, which kind of looks like a woven mat or a basket weave pattern. And third, obliterative phlebitis. This is where the inflammatory process actively targets and chokes off the veins. You might also notice some mild to moderate tissue eosinophilia, but those 3 core features, they are identical whether you're looking at a salivary gland, a kidney, or a lung. This image brilliantly illustrates exactly what we're talking about. Looking at a biopsy from a patient with hypertrophic pachymeningitis, you can see that distinctive basket weave, store-form fibrosis literally swirling around and encasing the cellular inflammation. And honestly, this tissue could be from almost any affected organ. The pattern would look exactly the same. Right in the middle, you can see a vein being completely choked off. That's your obliterative phlebitis right there. It's a powerful visual of just how much this disease targets the vasculature at the microscopic level. All right, part 3. Systemic involvement, a variable vessel disease. So, having seen the microscopic footprint, let's map out how this behaves systemically. IgG4W-related disease can strike almost anywhere in the human body. Officially, it's classified as a variable vessel vasculitis. That means it can target blood vessels of any size, small, medium, or large, on either the venous or the arterial side. In the pancreas and biliary tree, it triggers sclerosing cholangitis and autoimmune pancreatitis, which, if missed, can quickly lead to hepatic or pancreatic failure. In the kidneys, it drives tubulointerstitial nephritis, causing profound renal atrophy. In the lungs, it shows up as obliterative arteriitis, mimicking severe primary pulmonary diseases. And vascularly, it is notorious for causing aortitis, inflammatory aneurysms, and even medium vessel coronary arteriitis. It is relentless. To give you a sense of this systemic impact visually, look at how the disease manifests in the head and neck on an MRI. You've got severe thickening of the extraocular muscles in the orbit. That's orbital myositis, which actively threatens the patient's vision. And you also see nodular hypertrophic pachymeningitis at the base of the brain, causing this extreme thickening of the meninges. It's a true multi-system chameleon, popping up in incredibly diverse clinical phenotypes depending entirely on which organ systems it decides to target. Which brings us to part 4, the diagnostic workup, and something called the prozone pitfall. So we know the tissue biopsy is critical, but serology is our next major tool. However, it comes with a massive, massive trap for the unwary clinician. Think about this for a second. If the disease is literally named after and driven by IgG4 positive plasma cells, how is it possible that a patient with aggressive, multi-organ involvement could show completely normal IgG4 levels on a standard lab test? It sounds completely counterintuitive, right?
Well, the answer lies in this fascinating and dangerous laboratory quirk known as the prozone effect. Standard nephelometry assays rely on a very specific ratio of antigen to antibody to form complexes that the machine can actually read. But when a patient's serum IgG4 levels are incredibly high, we're talking maybe 30 to 40 times the upper limit of normal, there are so many antibodies that they actually prevent those complexes from forming in the first place. This completely overwhelms the assay, giving you a spuriously low or falsely normal result. The real tragedy here is that the patients with the absolute worst multi-organ disease are the most likely to experience this, putting them at huge risk for misdiagnosis. The only way around this? You have to specifically ask the lab to heavily dilute the serum sample before testing it.
Finally, part 5, targeted B-cell therapies. Obviously, getting the diagnosis right directly informs our management, and our approach to treating IgG4-related disease has evolved super fast. For asymptomatic, indolent cases like isolated lymphadenopathy, we might just stick to watchful waiting. Historically, glucocorticoids were the traditional first-line therapy, but as we know, they carry heavy systemic toxicity over time. So now we've moved to targeted B-cell depleting or modifying agents like rituximab. And here's why this is so brilliant. The IgG4 molecule itself is actually pretty weak and non-inflammatory. The actual tissue damage and that crazy fibrosis, that's being orchestrated by CD4+ cytotoxic T cells. Rituximab comes in and wipes out the B cells and plasmablasts, which interrupts the cellular crosstalk feeding those destructive T cells. This rapidly drops IgG4 levels and hits the brakes on the fibrosis. And looking to the future, highly targeted CD19+ modulating agents are already in advanced phase 3 clinical trials, which is huge for managing these complex clinical phenotypes. To wrap all this up, this master mimic has taught us an incredible lesson. Precise pathology leads to precise pharmacology. By finally recognizing the hidden links between these once separate diseases, we've completely revolutionized how we treat them. And it leaves us with a pretty provocative question to end on. As we continue to unlock the intricate cellular crosstalk driving IgG4-related disease, what other mysterious, so-called idiopathic fibrotic conditions are out there, just waiting to be conquered by targeted therapies next? Thanks for joining me on this explainer. And keep questioning what you see.